Talia. I'm the wound care coordinator. All the wound care consults come to me. Braden scores of 12 or less all come to me. You'll see me out and about on the floor all the time. And always stop me if you have any questions, but we'll go over this. So what is a wound? An acute wound is a disruption in the integrity of the skin that heals in a reasonable amount of time. So, you know, chronic stuff or traumatic stuff like gunshots, stabs, anything self-inflicted. If it heals in about 4 weeks, uncomplicated, that's an acute wound. If it takes longer than 4 weeks to heal, then it's considered chronic, no matter how it started. You know, like a diabetic patient maybe had a traumatic injury to the foot, it doesn't heal in a month's time, then it's considered a chronic wound. Types of pressure ulcers. I don't expect anyone to be able to stage this. This is just to help you guys recognize it. Right now in the hospital, we only have physical therapists, providers, and myself that stage. Stage 1s are, you know, just non-blanchable redness that is, non-blanchable redness, like so when you press on it, it doesn't turn white, and it's on any bony prominence. It could be even on the nose from a CPAP, or on the ears from oxygen. On the nose and the ears, they do go to a stage 2 very quickly because there's not a lot of thickness to the tissue there. So a stage 2 are ulcers that are very superficial, just kind of the top layer of the skin is gone. Also, any clear fluid-filled blister on a pressure point is also considered a stage 2. Now, if it's a blister due to disease process, you know, front of the shin or something like that, then of course that's not pressure related unless they have a medical device on it, and that can also cause it in an area that wouldn't traditionally have pressure.
So you mean like when people have cellulitis, then it kind of gets, do you understand when
If they have cellulitis and they get a blister, yeah, that's not a stage 2, that's part of the process of cellulitis, so it, you know, that's just part of the disease process with that. Now, if it was on the heel and the patient had cellulitis and the heel rested down, then that could be a stage 2. Stage 3, these are full thickness that go through both layers of skin into subcu, but not to muscle or bone. So these usually have nice red granulation tissue. Sometimes we will wound vac these, and stage 4s as well. Anything is stage 3 or above, I consult Dr. Jones. She's our wound care physician, so she manages the 3 or above. Or if I have, you know, several 2s that are significant, I'll consult her for those 2. Stage 4s, these are extensive, penetrate through skin into the deep tissues. They often have exposed bone, or you can feel the bone through the base. A deep tissue injury, these are always on pressure areas. It can also show up later after a patient has had a fall, and it can be like, I had a patient that had one kind of up here on the flank from a fall, and it was weird because it was like a perfect square shape. I'm not sure what he fell on, but it was really cool looking. This could be intact or non-intact skin. It feels different than the tissue around it, like it's either hard or it can be boggy. Like you can really tell a difference. Sometimes it's confused for bruising. You always want to check and see, you know, if it's in an area where you feel like it might be a bruise, look at what the patient's had on. Have they been wearing a brace? Have they had on the SCDs? Was something causing pressure that maybe you wouldn't have thought? Also, blood-filled blisters due to damage to the underlying tissue. Those are considered deep tissue injury, so anything that's not clear. These could be warmer or cooler than all the rest of the tissue, and these will almost always open if we don't put offloading in place. Generally, if I see a patient with a deep tissue injury, we use a leave-in. That's our foam. I'll show that to you in a second. And we do specialty beds, Q2-hour turns, and all of the offloading measures, geomats in the chair. Unstageable pressure ulcers, these are full thickness tissue loss, but they're covered in either a slough or an eschar, and you can't tell how deep the wound goes until the stuff is removed. Like this would have to be debrided, most likely surgically, or they can sometimes use Santal, which is an enzymatic debrider, but these will always go to Dr. Jones as well. So for your impaired skin integrity, when you see anything non-blanchable, open ulcers, fluid-filled blisters, significantly discolored skin, The following should be initiated. You always want to do your impaired tissue integrity care plan. Now there's also a risk for impaired tissue integrity care plan. If there's open skin or something non-blanchable, you always want to change it to your impaired. So you want to initiate appropriate interventions with the care plan, things like geomats, our egg crate heel protectors, Sensicare, the Tegaderm absorbent, or the leave-in foam dressing. None of those require a physician's order. You can initiate all of those without the doctor. We don't have care plans built for these currently. TS is working on it, so they'll be coming out here in the next few weeks. You always want to photograph and measure the area per standard, and we'll go into that in a second. And consult me if I'm not already consulted. However, if it's a patient I'm consulted on and you find something new, don't do a reconsult, put in a communication to wound care. And you don't need a doctor's order to do that. You just go like you're adding an order. If you type COMM wound, it pops up, and this, like, you can type in a little message and that goes right to my list. So cellulitis, this is the one that we were just discussing. This, while it is non-blanchable redness, it's not on a pressure area. So unless there's an open wound, this does not require a wound consult for myself or Dr. Jones. The treatment for this is antibiotic therapy. Types of tissue. So when you're looking at a wound and you're like wondering kind of what to call the tissue and how to describe it, you see the top one here is that it's kind of that viscous yellow material. Sometimes it's slimy, sometimes it's hard and almost leathery. That we refer to as the slough. And then this down here is granulation tissue. That's when it's nice, pink and red. It's got like almost like a bumpy surface, like when you buy, people don't like it when I compare food, but that's really the easiest way to do it. When you buy a hamburger, how it's got that wavy part, that's kind of how granulation tissue is. It's like got all these little lumps in it. If it's dusky in color, there generally is a perfusion issue, and that wound is going to heal very slowly. So denuded skin, this is loss of just the top layer of skin, excuse me, usually from stool, urine, sometimes wound drainage. Sometimes if you have a patient that drains a lot from
Colostum.
a colostomy, there we go. The skin around it will get irritated, and that's what we call denuded. Now I'm going to point something out in this picture here. Can you tell what that is?
It's like a butt.
Is it a butt? Is it an abdominal fold? That's why it's so
yeah.
important to put the location when you're taking a photograph of something. Excoriation, this is often used interchangeably with denuded, but it is very different. This is like loss of epidermal, like from scratching, like it's in lines. And generally people who have that denuded skin, like especially if it's like under folds or something like that, they also have excoriation because they do scratch. Suspected yeast. We always say suspected until a doctor has said that it is yeast. This is a perfect example, but do you see something wrong with this picture as well?
Yeah, no,
Not using gloves.
Right, there's an ungloved hand. We don't know, is that the patient's glove or hand, is that the nurse's hand? Always have gloves on when you take your photographs. So this can be in the abdominal folds, beneath the breast, in the axilla, anywhere where skin touches skin. They get this classic rash. You see these little satellite lesions that kind of come off of it. That's classic yeast. It also has a distinctive smell. With this, you would get a doctor's order. We have a 2% miconazole that you can get an order for from pharmacy that is an ointment, and then we also use nystatin powder. Then of course describing this in your charting is, you know, reddened folds, satellite lesions, moist, inflamed, and malodorous usually. A scab versus an eschar. I hear these used interchangeably all the time, and they're very different. Eschar is dark, it's leathery, it's not a natural thing for your body to do. A scab is like a natural dressing, it doesn't need debrided. Usually left alone, it'll heal on its own. Eschar, it's dead tissue, it's usually full thickness, and it will have to be debrided. Most of the time with what we would do with this, we would paint it with a Cavalon skin prep and leave it alone until doctor assesses it. Definitely offload though. So which care plan to choose? Always unbleachable redness on a pressure area, open ulcers, any significant types of skin problems and locations that you may encounter. So like significant skin tears, things like that, you always want your impaired tissue integrity care plan. Your risk for is patients who maybe have red, but it's blanchable, but they have poor nutrition, poor mobility, a high BMI, a low BMI, your really little skinny ladies and old men, you would always have a risk for impaired integrity in there. And then a suspected yeast care plan with the rashy folds. Also, if the nystatin or the antifungal ointment are ordered, you need this care plan. So it's like if you have a seizure med ordered, you have a seizure care plan, the same thing. A yeast med is ordered, so you have your suspected yeast care plan. So the skin and wound image capture process. All wounds or any skin abnormalities that you feel like you're going to have difficulty describing need photographed on admission, on Wound Wednesdays, and at discharge. Say you notice something new that wasn't there before, it's not Wednesday, go ahead and take a picture of it. Also, you know, if someone else took a picture of like a scab and you're like, that doesn't need a picture, you don't have to photograph something just because someone else did. The way that we photograph, there's like the iPod touches on the units. You kind of log into it, you choose your patient, you take your photograph, make sure it's clear. You can rename it right there on the phone or iPod touch, and it goes right into the documentation. You don't have to do anything else with that. Yeah.
Do you have do you use one of those card things, or do you just take a picture of it? You know how you have one of those card things that you measure with?
It was in front of the computer.
What did I do with it?
It was in front of the computer.
Use a ruler. You put the patient's sticker on it. Always put the location on it. And then what else I like to do is put an arrow at the direction the patient's head is going. So if you're taking a picture of like something on the belly and you know that it's pointing up, you know it goes up and down on the belly and not side to side. That way you can tell where it's at on the human. Photographs should always include, I just said that, didn't I? Always make sure they are clear. Sometimes I get in there and I like, you know, it's kind of a blurry picture like the iPod just didn't focus. Particular areas to pay attention to during your assessment, the ears and nose, obviously if there's oxygen or CPAP, the back of the head, the shoulder blades, the sacrum and the coccyx, elbows, heels, buttocks, and hips. The other area is kind of the ischium, right on the sits bone. If you have a little guy who likes to sleep in the chair all day, those areas tend to like to break down. Okay, measuring a wound. So when you measure a wound, you consider the face of a clock with 12 at the head and 6 at the feet. We always measure in centimeters. And we measure wounds on Wednesday when we do photographs, and of course anytime that we find one. So this is my friend Seymour, and if you were going to measure his wound, you would always go from top to bottom and then from hip to hip, and that's how you would measure him. Sorry. There it is, cotton swabs. You always want to moisten these when you're measuring a wound because when you probe into a wound with a dry cotton swab, it's not really very comfortable. So I'll just kind of show you how we would measure on him. You would go from the longest edge to the longest edge. So this guy's is pretty round, so his is easy to do. But if it was abnormally shaped or there was a piece that kind of came up here, then you would go from the top part of that piece to the bottom. You don't do from like the longest to widest. You never want to turn the clock. So it's always from top to bottom, side to side. So if you're going to measure this guy, you've got about 5.2 by 5.4. So then that would be your length and your width. Also on these, it doesn't start at the edge. It kind of makes me a little crazy, so always make sure you're starting at I want it to be like right on the end. So when you go to measure your depth, you have your cotton swab and you kind of just put it in the deepest part of the wound and then you slide your fingers down to the edge of the skin and then you hold it to your ruler, and that would be about 1.5 in depth. So then when you're doing undermining or a tunnel, so this guy kind of has undermining, which is like a little lip where the wound goes under the skin all the way around. So you would say he has undermining from 12 to 12. That indicates it's all the way around. If it was only from here to here, you would say 12 to 3. Or, you know, down here it would be like 7 to 9. So then to measure that, you kind of find the deepest part, and same thing, run your fingers to the wound edge, and there's your undermining. So you would say the patient has undermining from 12 to 12, and it is 1.3 centimeters in depth. For sinus tracts or any tunnels in the wound, you do the same thing. Just gently probe. You don't want to push any further once you feel slight resistance, because you can make things deeper. So this one has one kind of over to the side. I don't know if you guys can see it in there. There's a little tunnel. So you put your Q-tip in the tunnel, and the same thing. You go to the skin edge, hold it against your ruler. So that would be about 2.5 centimeters, and you would say there's a tunnel or a sinus tract that is 2.5 centimeters at 10 o'clock. And so that's how you would know where the location of your tunnel was. So if you look at someone else's documentation and you see that they documented a tunnel and you can't find it, maybe it's not there anymore. They do close up, or maybe you just need to go up or down a little bit. All right. And this is actually named Seymour. The company did it, not me. So a wound care consult, that's when you would want to consult me, and this is for, you know, your non-blanchable redness, open wounds with visible fibrin or slough or necrotic tissue. A Braden score of 12 or less automatically prompts me, and I do a skin assessment on patients who have a Braden score of 12 or less, and I will add interventions to your care plans. I don't initiate care plans. So you may get a communication in nursing from me that says, please initiate impaired tissue integrity care plan. I'll follow all the patients until they're discharged. The only patients that I take off my list is a Braden score that I have fully assessed, that the Braden score has improved, and they don't have any skin issues. I can assist you in assessing the patient. I can make recommendations for treatment and prevention. I can help you call providers if you need orders for things. And obviously, if you need to get a hold of me, my number is up here. It's 341-4057. I am in the Rolodex as well, and on the call schedule. We do have a wound care nurse on call 24 hours a day. The pager number is 901-6600. That's also in the call schedule. If you have trouble with a wound vac or something like that, and you can't get through it with basic troubleshooting, always call sooner than later. Don't let your wound vacs go non-functional for very long. And then this is the new in the eye view. This is where you consult. This is when you go through your assessment. If you click consult wound care and click yes, this little yellow box now pops up, and you have to type a reason in there of why you're consulting. This is really a benefit to me with the transition, because before I really couldn't tell what I was consulted for unless there was a photograph in the chart. Also, you don't want to consult me for surgical incisions. Surgeons manage their own incisions, and they like to keep their orders. If you have a complicated dressing that a surgeon's ordered, though, absolutely call me and I can help you go through it. So just some day-to-day stuff that Dr. Jones asks me to share with everyone. An ABD pad has this little blue line. It always goes away from the patient. So if you were going to put this on a patient, it would go like that with the blue line out. Care plans are your care plans. You can change and manipulate those care plans as much as you want. You can change as much as you want during a shift. If night shift puts something in, you're like, I don't feel like that's appropriate, that's yours to change. If I put something in and you feel like it's not appropriate, you know that patient better than I do. You are free to change that. Just let me know if it's something that's, you know, very significant. Sensicare, Adaptic Geomat, the Heel Protectors, Aleve, Tegaderm Absorbent, all of those things can be initiated without a physician order. Just they're not currently in your care plans, so you'd want to go to the patient-specific intervention and add that you've applied something like that. You always want to date those when you apply them. And if the patient can't get up on their own and go to the bathroom on their own, always put a geomat in that chair. Our chairs are hard. They don't breathe. The geomats are mostly stocked on the floor, and if you can't get one on the floor, call distribution, they'll get it up to you. There are 2 layers of plastic on the geomat. The top one is like a cellophane, like a trash bag. That you want to tear that one off, but leave the other one on. It's slick, it's like smooth, it's breathable, it's kind of like velvety, so it helps if the patient has an accident, it doesn't soak into the foam of the geomat. Obviously, if you see me rounding, always stop me. Ask me any questions that you have concerns with any patients. And once again, reconsults just fall off my list. Always use communication to wound care. So your Sensicare, this is the one that you want to use for patients who are incontinent and have really red incontinence-associated dermatitis. That is the maroon and white. This is to be applied very, very thin. You should be able to see the color of the skin through the Sensicare. I can't tell you how many times I've turned a patient over and their butt looks like a mime, and this stuff is impossible to get off. You also don't have to clean it off every time. You just clean the top surface off, and you don't have to scrub the skin. You'd want to use a disposable wipe rather than a washcloth if you were trying to take some of this off, because the washcloth will just tear the skin up. It helps if when you go to apply it, if you warm it up in your hand a little bit first, it helps it spread thinner, but this stuff is really thick. The product line that we have here is the Alavesta. There it is. I think my phone soap's sitting on my desk. I got it out to show someone. Oh, no, it's in my hand. It's been a long week. So your cleansing foam, this is the one that can be used anywhere, peri-area, hair, face. This doesn't have to be rinsed either. Our moisturizer looks just like this, but it has a 2 on it, and it is for intact skin only. If you put that moisturizer on denuded or excoriated skin, it burns. And then this is the body wash and shampoo. It's pretty much the same as this. These 2 are interchangeable. Neither one of them need rinsed. This is the protective ointment. This is a skin barrier cream or ointment that it can be used on anyone. This can be applied as many times daily as you want to. You have a lady who has some stress incontinence, this is perfect. Put this all over her behind so that it protects it from that urine on her skin. And then we also have the Alavesta antifungal. It's available in pharmacy. You do need a physician's order for that. But as soon as you notice any signs or symptoms of yeast, this can be your first line before you go with the nystatin powder. This is, much less expensive, and it comes in kind of a larger tube. So try this first, and then if that doesn't help, then we go with the nystatin. Wound vac tips: you can use the Cavalon Skin Prep, the no sting barrier. If you suspect your wound vac has a leak, you can take this, we call them lollipops, paint all over the dressing. This is not going to hurt your wound vac drape. It kind of like you can either see it pull into the sponge or makes a hissing sound, kind of like when you're checking an inner tube for like a hole with soapy water. Same principle. Sometimes this will seal it, but at least you would know where to apply your wound vac drape. You wouldn't put it all over everything. You would put it where this would hiss. Never ever use Tegaderm to patch a wound vac drape. I always leave extra drape in the room. If there's not, you can call distribution and they will send you just a package of wound vac drape. The prompts on the machines can help you determine a problem. It'll say leak versus blockage, or it may say pressure change, or it might have a little flashing thing that says seal check. That's when it's a leak. Always use the pager after hours if the troubleshooting is unsuccessful. I change, I measure, and I photograph all of the wound vacs. That's not something you guys have to do unless a patient is being discharged. I cannot put enough emphasis on this. I've had 4 wound vacs sent out in the last year. That is $100,000. Those machines are 25 grand a piece. Don't ever, ever send your wound vac to another facility. I have gotten them all back. I had to have a FedEx guy who goes to Smithville pick one up from a rehab just recently. The other one went to KU. I had to call the KCI rep and give them the patient's room number. They went and got it for me. So don't ever send a hospital machine out. There are home wound vac machines that we deliver to patients. They're small, they're in a black bag, they're very different than the hospital machines. So you'll always know which one you have. So if you have a patient discharging with a wound vac, this is not in the standard yet. We're waiting on TS to update it, so it'll be in your care plan. The dressing has to be removed completely. When you look on a dressing, there's always a label that says how many sponges are in there, so you want to make sure you get the sponges out. So the dressing's removed completely and a hydrogel dressing is applied. So the way you would do a hydrogel dressing is there it is. So Solicite is a hydrogel. It's basically saline in a gel form. So you would apply this to the base of the wound, or you can impregnate a piece of gauze with it and you would tuck it in the wound, cover it with an ABD pad, and secure it with Metapore tape. So then the patient is going to get a wound vac at another location. They can assess the wound themselves, do their photographs, and then they reapply the wound vac there. We don't send a patient out with a wound vac dressing on unless they're going with a home wound vac. Any questions about that? I'm kind of protective of my wound vacs in case you can't tell. So the new dressings that are available, these are 3 that we just got recently. We're working on some more. This is our Alleven, a protective silicone dressing. This can be applied to the buttocks. You can apply these to heels. You can apply them to elbows. Anywhere that the patient has pressure, this can be applied for prevention. If you just put a P on it and the date, you know that that is for prevention, that there's not a wound under there, and it can stay in place for 5 days. If there is a wound under there, you would do a T for treatment and then put your date on there, and that can stay for 3 to 5 days depending on the physician or how much drainage the wound is having. So this one's a sacral one. I've actually found that these work better like this. I don't know why. This little tail just seems to always get in the way when there's stool or anything like that. It goes up the spine perfectly when you flip them this way, but this usually seals right above the rectum or the gluteal cleft, depending on how high the wound is. So I know they're supposed to go this way. They work better this way. So this one is called the sacral dressing. This one is called a quadrilobe. These are all available from distribution. Some floors stock them. There's a couple different sizes of the little quadrilobe. We have this little cute one. And then this one, I believe there's one in between these two. I don't have an example of that one right at this moment. But these do really great if you have a red spot that's even blanchable. Put one of these over it, in a day or 2, it's generally gone. And I had a patient that had a pretty significant deep tissue injury to the coccyx. We kept one of these on and it never opened, which is something that we've always had, kind of an issue with until we got an offloading foam. If it is on a wound, the drainage, the way we know that this needs changed is a 75% saturation. So you see this little line right here? If 3 of these lobes get saturated, then we know it's time to change. With the sacral one, it's 75%, but you can see it in this line. It's kind of like an indicator. That line gets a little darker so you can see where the drainage has been pulled into that. All right, any questions on those? And then our next one is the Cavalon Skin Protectant. It's over here because I just grabbed one. This is like Rain-X. It covers about a 10 by 10 centimeter area, so if you have a large patient, you would want to use 2 of them, kind of one on each cheek. This takes about 60 seconds to dry, so if you're doing it kind of between folds, you got to hold them up for a little bit, because if you put it down, it will stick together. This stuff is not like the skin prep, but not quite Mastisol. It's kind of in between, but It doesn't have to be washed off. It can be used once or twice a week, depending on the problem. Anybody who has incontinence-associated dermatitis, like the really red sore butt, this will not harm that. You can go over the whole thing. This can also be used, like say if you have a patient that has a colostomy, you can use it around that to help protect the skin, and it won't affect your seal of your appliance. And then the next one, this is a Tegaderm absorbent. This comes in a couple of sizes. There is a little one. It's much different in the Tegaderm in that it has this acrylic, I'll pass it around so you guys can feel it. There's like this little pad in it that's acrylic. It actually evaporates drainage out. So you can put this on and it'll kind of blister up, like the drainage will make a bubble underneath it. And then the drainage will just kind of evaporate out and it'll get kind of dry. This can stay on for up to 21 days. So you have a skin tear, this is perfect. You don't take it off to take photographs, you don't take it off for the patient to go home. You take your photograph through it because it is see-through, you can see the wounds underneath it. You will see drainage that obviously kind of obscures a little bit, but you can still tell that it's clean and it's dry and it's intact. But if you guys want to feel that one. And that's for low to moderate drainage, because if you use it on a really heavy draining wound, it will bubble up and it'll come loose on one side. You can use the skin prep, this to help secure those. You can use this to help secure your leave-ins. Your leave-ins can be peeled up to assess the wound and then stuck back down. The only time that you want to change this before, the 5 days with the saturation is if stool gets beneath it. If it gets on the top, there is a barrier, you can just wipe it off. Any questions? I know it's a lot in a little amount.